All right, everyone, welcome back to our next lab presentation where we're going to start discussing the physiology of the heart. In our last lab presentation, we discussed the anatomy of the heart and the physical structures that can be found on it. We discussed the different chambers and the different valves of the heart and the pathway that blood takes as it travels through the heart. By now, we should be aware that there are two major circuits, the systemic circuit and the pulmonary circuit. And in order for blood to continually pass through each of those circuits, the heart has to function as a double pump. The right side is pumping into the pulmonary circuit, and the left side is pumping into the systemic circuit. So here in this lab presentation, we're going to focus on how the heart continually pumps through both of those circulations, and we're also going to discuss some methods that can be used to discuss the overall health and the overall functionality of the heart as a whole. So in order for us to get an idea of how the heart continually pumps, we have to learn the members of the cardiac conduction system. The cardiac conduction system is made up of the elements that keep the heart beating at all times. The cells that can be found in this system display a characteristic known as autorhythmicity, which means that they're able to generate their own action potentials all on their own without any outside influence. The cardiac conduction system consists of 5 different components, namely the sinoatrial node, or the SA node, the atrioventricular node, or the AV node, the atrioventricular bundle, or the AV bundle, the left and right bundle branches, and the Purkinje fibers. In this order, signals are passed from component to component, and these signals will excite the cardiac muscle in the proper order to facilitate a continued contraction of the heart walls. Let's take a look at where each of these components can be found within the tissue making up the heart. So here you can once again see that coronal section of the heart and all of the 5 components of the cardiac conduction system superimposed onto the picture. First and foremost, we have the SA node, which is also often referred to as the major pacemaker of the heart, because the SA node is the component of all 5 of these that fires the fastest. This is going to be the one that sets the pace of the heart. And the SA node will send signals out, and that will be what excites the rest of these members of the cardiac conduction system. So when the SA node fires, that signal is going to get propagated throughout the walls of the atria, and the atria are then going to squeeze blood through the 2 atrioventricular valves. The atria are going to squeeze that blood into the ventricles, and while the atrial walls are contracting, that signal is propagating along to the AV node. The AV node will be found in the wall of the right atrium, and so once that signal hits the AV node, that is then going to transition that signal from the atria into the ventricles. So the AV node is then going to start firing this signal down the AV bundle of His, which will continue to propagate into the right and left bundle branches and then out to the Purkinje fibers. As the signal starts to make its way through the bundle of His, the bundle branches and the Purkinje fibers, the ventricles are then going to start contracting. Once the atria have squeezed all of the blood into the ventricles, the atria will relax and then the ventricles will contract. Now remember, we have the papillary muscles and the chordae tendineae that are present here to keep these valves from inverting. So when the ventricles squeeze, that's going to force blood through the semilunar valves out of the aorta and out of the pulmonary trunk. Here is just another picture of everything we saw on the last slide, but with a little bit better graphics. You can see the SA node shown up here, the AV node shown here. Extending from that is the AV bundle of His. We have our right and left bundle branches, and then the Purkinje fibers that will course throughout the walls of the ventricles. Now, as I've already mentioned, the SA node is what gets the name as the pacemaker of the heart, because the SA node is the member of this conduction system that fires the fastest. Since the SA node is firing faster than any other of these members of the conduction system, it will be the component that sets what is known as the normal sinus rhythm, which is just the normal heartbeat. So roughly, the SA node fires on average about 75 times per minute. Now, of course, everyone's heartbeat is a little bit different, but one group of individuals that are particularly different are athletes. Athletes will generally have a much slower normal sinus rhythm than individuals that are not athletes. Athletes will often have bradycardia, which is a slow heart rate, and this is because their heart is especially used to functioning under conditions where the heart normally has to beat a lot faster. Now, the SA node is not the only factor that displays autorhythmicity. In fact, the AV node, the AV bundle, and the bundle branches are all going to be autorhythmic fibers. But because the SA node fires the fastest, It is what sets the normal sinus rhythm. Now, in the event that the SA node is damaged for some reason, the AV node is then going to pick up as the major pacemaker of the heart. The AV node fires 50 times per minute, so it's not necessarily as efficient as the SA node is. But if for some reason the SA node is destroyed, the AV node will still display that autorhythmicity if the SA node is unable to do its job. The same thing is true for the AV bundle and the bundle branches that only fire 30 times per minute. So whatever the fastest firing component of the cardiac conduction system will be the member that controls the heartbeat and sets the pace of the heart. Okay, so a big portion of cardiac function is understanding how to assess the condition of the heart based on the electrical currents that are passing through it at any given time. And this is a branch of science known as electrocardiography, or the ECG. We're going to take a look at the electrocardiogram and see how it can be used to assess cardiac function. The ECG is showing a graph that measures voltage over time, and from this, through the heart, we get three different deflection waves: the P wave, the QRS complex, and the T wave. Each of these waves will generally be different sizes, different lengths, and occur at different intervals throughout the course of the cardiac cycle. And based on the shapes that these waves are on the ECG, that's going to give us a lot of information about how the heart is pumping blood. So your lab manual sheets will go into all of the specific changes and what they mean, but here we want to focus a little bit more on the meaning that can be derived from an ECG tracing. So here you can see a little graph with this very, very thick line on it, which is showing us the ECG tracing. Now, one other thing that I am also going to mention is that the ECG can often be referred to as the EKG as well. They mean exactly the same thing. We get the letters ECG from the way it's written in English, and we get the letters EKG from the way it's written in German. But it all means the same thing, so if I use the phrase ECG or EKG, you'll now know what I'm talking about. The next thing that we need to understand is that on the y-axis we're measuring voltage, and on the x-axis we're measuring time. I'll show you some other diagrams that will demonstrate this a little bit later, but just start to make that association right now. So what you can see here is that this EKG tracing has a few waveforms that are all labeled with letters. This here is the P wave. Here we have the QRS complex, which is very, very sharp and tall. We're going to have the ST segment, and then we're going to have the T wave, which is shown right here. So each of these different waveforms appears at a given time throughout the cardiac cycle. And each of those waveforms is also going to indicate something that's going on during the cardiac cycle. So first and foremost, you can see the P wave is indicating atrial contraction, also referred to as atrial depolarization. When the atria depolarize, they contract. So those two words are going to go hand in hand. So the P wave here is indicating atrial contraction. Whenever we see this waveform, that means that the atria are squeezing blood into the ventricles through those atrioventricular valves. Now the QRS complex, which is going to be shown right here, is going to indicate ventricular contraction. And so since the ventricles are going to be the most active chamber at this time, you'll see that the QRS complex will happen after atrial contraction. We're always going to have atrial contraction squeezing blood into the ventricles, and then the ventricles can contract because they've been filled up and can now push that blood out into the circuits. Over here we have the T wave, and the T wave is going to depict ventricular relaxation. So this here is going to be a much longer wave than the P wave will be, and it's going to be a little taller as well, usually. But now that I've just mentioned that we have a T wave indicating ventricular relaxation, you're probably wondering if we have a wave that's here for atrial relaxation. Well, atrial relaxation, of course, is something that needs to take place, but it's going to be masked and hidden here inside of the QRS complex. So if we were just measuring the atria, we would see atrial repolarization or relaxation taking place somewhere around here. So of course, just keep in mind that contraction means depolarization and relaxation means repolarization. So hopefully the EKG tracing is falling into place. We've got these different waveforms, and each of them are going to indicate a different event taking place throughout the cardiac cycle. But that's not all we're going to see here with an EKG tracing. We're also going to have various intervals and segments that depict different time intervals that take place throughout the cardiac cycle as well. And these are the PR interval, the QT interval, and the ST segment. Let's first describe the PR interval, and we'll make our way through the rest. The PR interval stretches from the beginning of the P wave to the beginning of the QRS complex. So essentially from the beginning of atrial contraction to the beginning of ventricular contraction. This PR interval includes all of atrial contraction. We also have the QT interval, which stretches from the beginning of the QRS complex to the end of the T wave. So this interval is showing us the duration of the entire ventricular depolarization-repolarization cycle. And then we're also going to have the ST segment, and the ST segment stretches from the end of the QRS complex to the beginning of the T wave. This is going to indicate the amount of time it takes from the ventricles depolarizing to begin repolarizing. So each of these segments will indicate a different part of the cardiac cycle. And depending on whether or not one of those segments is elongated, perhaps it might be shorter, one of the waveforms might be higher or lower than it's supposed to be, all of those can indicate issues with that cardiac cycle. Again, your lab manual sheets will go more into this, but I just want to give you guys an idea of how to read the EKG and what each of these waveforms and segments means. You'll see that this slide pretty much contains all of the information that was discussed on the last slide. You see the PR interval here, the QT interval here, and the ST interval shown here with all of these different waveforms. So the next thing here that we need to look at with the EKG tracing is being able to relate time intervals to the events that we see traced. When a patient's EKG tracing is being taken, this piece of graph paper is being run through a machine at a particular speed, and that calibrates each one of these tiny squares with a particular time interval that we can use to see how long certain events take place. So you can see each of these time intervals shown up here. Right here we have a small square, which is worth 0.04 seconds. Here we'll have a large square, which is worth 0.20 seconds, and you can see here that if one small square is worth 0.04 seconds, and there are 5 small squares in one large square, it would make sense that we just simply take 0.04, multiply that by 5, and that's going to give us 0.2 seconds. That's 1/5 of a second. So based on that information, 5 large squares are shown here, and that's going to be a total of 1 second. So the small squares are worth 0.04, large squares are made up of 5 small squares, and those are worth 0.2 seconds, and then 5 large squares together will make up a single second. So we're actually seeing an EKG tracing of 1 second here on this slide. That's how long it took for all of these events to take place. So with this information, we can now not only see the EKG tracing itself and the size and duration of each of the waveforms, but additionally, we can now calculate the duration of many cardiac cycles, which can be ultimately translated into calculating the heart rate. So there will be 3 different methods I'm going to show you for how we can calculate the heart rate from an EKG tracing, and each method will be used in different circumstances. But this first method is going to be the most accurate, and all you really need is a single tracing of one cardiac cycle. So the first thing that you're going to do is count the amount of small squares that are in one complex. One complex is one cardiac cycle. And you're going to multiply that number by 0.04. That's basically going to show us how much time it took for one cardiac cycle to take place. So we're going to go ahead and start right here, and we can see that using our information on large squares, we have one large square, so that's 5 small squares. Here we have a second large square, a third large square, and a fourth large square. So 4 large squares in total is 20 small squares. So we're going to take the number of small squares and multiply it by the amount of time that each of those small squares contained. So 20 times 0.04 gives us 0.8 seconds for every beat. That's telling us that this heartbeat took place in 0.8 seconds. So we're going to take this number and divide it into the number of seconds that is in 1 minute, which is 60. So 60 divided by 0.8 seconds is 75 beats per minute, which is right around where our normal sinus rhythm should be. So this is the first method that I'm going to show you for how we can calculate the heart rate. Here on this picture, you'll just see another EKG tracing that's a little bit nicer than the one on the last page. You can see this is exactly the same type of tracing. We have our first P interval, which is going to start right here, and we're going to count the amount of small squares in one whole complex. So you can see right about here is where the next P wave would have taken place. We count the number of small squares, or we could count the number of large squares and convert that to the number of small squares. We have a total of 20 in here. 20 times 0.04 is 0.8, and then 0.8 divided into 60 gives us a 75 beats per minute. Now, one other thing I do want to show you on this slide is you can really see up here that the voltage is measured in millivolts, and then time down here is measured in seconds. So you can see that seconds is on the x-axis and voltage is on the y-axis. As time progresses, we are measuring the voltage that is passing through the heart. Now, the next method that we're going to see here is the times 10 method. Now, in order for the times 10 method to work, you will need an EKG tracing of at least 6 seconds. You won't always be given an EKG tracing of 6 seconds, so you will not always be able to use this method. But in the event that you do have a tracing that's worth 6 seconds, this will probably be the easiest one to calculate. So what you're going to do for this method is you're going to count the amount of cardiac cycles in that 6-second period. That's 30 large squares. So the amount of cardiac cycles in 30 large squares, and simply multiply that by 10, and that will roughly give you what the heart rate is supposed to be. Now, the third method, and this will probably be the one that I would recommend that you use the most because the mathematics are probably the easiest, is the 1500 method. The 1500 method simply takes the amount of small squares in one complex and divides it into 1500, which is the total amount of small squares in 1 minute. So what's nice about this method is you don't have to necessarily start at the beginning of the P wave. You can use the R wave, the Q point, the T wave, whatever part of the cardiac cycle that you want, as long as it's the same part in the first cycle as it is in the second cycle. So here you can see we have an EKG tracing. What we're going to do is we're going to start at the beginning of the P wave just for simplicity. You can see that the P wave is roughly going to start down here. So I'm going to go to the bottom of this page just so that we can go ahead and track as we count the number of small squares. So we can see that we have one large square here, that's 5 small squares, another large square here, 5 small squares there, another one here, and then you can see that this P wave is probably going to begin right around here. So we have a total of 3 large squares, and then this interval is only going to contain 4. So we can go ahead and count those, and we could say 1, 2, 3, 4, 5, 1, 2, 3, 4, 5, 1, 2, 3, 4, 5, and that's going to be a total of 15, and so we'd say 15, 16, 17, 18, and 19. So once you have the total amount of small squares in one interval, which is 19, you're going to divide 19 into 1500. And that's going to give you your heartbeat for this particular method. Now, the nice part about this method is that you can take anywhere on the EKG tracing and count up the amount of small squares in that particular interval. Now, the one caveat is you have to have a regular heartbeat for this method to work. But I won't be giving you any irregular heartbeats specifically when asking you to calculate the heartbeat. So you could take this particular point down here, this would be the S point, and you could go all the way to this S point and you'd still get 19, and that would give you a heartbeat of 79 beats per minute. So as long as you have a regular heartbeat, you can use the 1500 method. As long as you have a span of 6 seconds, you can use the times 10 method. Otherwise, you'll have to use the first method that I showed you, which will realistically be the most accurate. Any of these methods can be used to calculate the heart rate from an EKG tracing. So it might have been a good idea for us to discuss this slide a little bit earlier, but better late than never. This slide is going to discuss the simplified version of the cardiac cycle and introduce a little bit more vocabulary for us. So I've already discussed the word contraction and the word depolarization in terms of the cardiac cycle mean exactly the same thing. And I've also said that relaxation and repolarization are the same thing. But here we're going to add 2 new words, systole and diastole. Systole just means contraction, which also means depolarization. And diastole is relaxation or repolarization. So what we see here is that the cardiac cycle, of course referring to a single heartbeat, is made up of atrial contraction and relaxation and ventricular contraction and relaxation. So we say that atrial systole is contraction followed by atrial diastole, which is relaxation. While the atria are relaxing, the ventricles are contracting, and then the ventricles are going to relax as well. Atrial systole starts off the P wave, while ventricular systole is going to start off the QRS complex, and then the T wave is going to depict ventricular diastole. During the cardiac cycle, different sounds can be heard and are often described as lub-dub, which is not very scientific sounding if you ask me, so I refer to these sounds as S1 and S2. Now the heart sounds that you can hear with a stethoscope or by placing your ear on someone's chest, those sounds are caused inside of the heart by the valves closing and heart slapping into those closed valves. The sound that's often referred to as lub, or S1, is caused by the AV valves closing, and the second heart sound, dub, which is S2, is going to be caused by the semilunar valves closing. So when the tricuspid and bicuspid valves are closed, the atria are filling up, and no blood is passing into the ventricles. Meanwhile, the ventricles are contracting, and they're going to be forcing blood out of the pulmonary trunk and the aorta. When the semilunar valves are closing and we hear S2, that's going to indicate that the aortic and pulmonary valves have closed, the ventricles are relaxing and filling up with blood, and the atria are going to be contracting, squeezing blood through the AV valves. Now, S1 and S2 are not always the only heart sounds that we can hear. We also have a specific type of heart sound known as a heart murmur, which is not necessarily a sound that we want to hear. Heart murmurs indicate that one of our valves might be faulty, because backflow of blood is being allowed through that valve, and that's producing an abnormal sound in the cardiac cycle. So there are actually places on the chest that we can listen for specific heart murmurs in certain valves. You'll see here that at the second intercostal space, just to the right side of the sternum, is where you can listen for heart murmurs in the aortic semilunar valve. And here on the left side of the sternum at the second intercostal space, you can listen for heart murmurs in the pulmonary semilunar valve. Down here to the right side of the sternum, at the fifth intercostal space, you'll be able to listen for heart murmurs in the tricuspid valve, and over here you're going to listen for heart murmurs in the mitral valve, which is also known as the bicuspid. Now specifically, you're going to listen for this heart murmur at the point of maximal intensity, so it's not exactly in line with the left sternal margin. But specifically for our quiz, this is the only one that's going to be found in the fifth intercostal space to the left side of the sternum. So the next concept that we're going to discuss is pulse. Pulse is something that you've often felt on yourself throughout the years, but in anatomy and physiology, it's important to understand what pulse is so that we can arrive at what the pulse pressure is. Now the pulse you've probably heard before in your thumb, in your neck, or perhaps on your wrist. Your body's pulse is actually the artery rebounding because of blood that is filling the vessels when the ventricles are contracting. So we can use the pulse to determine what the heart rate is. Just a fun fact for you all, it's very important that you never check another person's pulse with your thumb, because you have your own pulse in your thumb, so you might not get a proper reading when assessing somebody else in that way. You're supposed to use your forefinger and your middle finger to assess somebody else's pulse. So here you can see various pulse points scattered throughout the body. Some of the more common pulse points that you'll see here are the pulse point of the common carotid artery, the radial artery, and also the brachial artery, which is what we'll use to assess blood pressure. But you also have pulse points for the temporal artery, the facial artery, the femoral artery, the popliteal artery, the posterior tibial artery, and the dorsal pedis artery. All of these are in fact places that you can use to monitor the heart rate, but the common carotid artery, the brachial artery, and the radial artery are most likely going to be the ones that you'll see in your future careers. Now when assessing pulse, you need to find out how many beats occurred in 1 minute. But in the healthcare field, it's not so efficient to spend an entire minute with every single patient just counting their pulses for that minute. So there's a couple fast pass ways that we can use to determine the pulse. So what you're going to do is you're going to take a multiple of 60 seconds and multiply it by the number to give you 60. So you count the amount of beats in 15 seconds and then you multiply that number by 4. Also, you can use 10 seconds and multiply by 6. So this makes sure that we have a way to maximize time with patients and to ensure that we're not wasting any time just sitting there counting all of the pulses in a patient for an entire minute. So our final concept for this lab presentation that we're going to get into is blood pressure. Now blood pressure, as I'm sure you know, is very, very important. Cardiovascular disease is the leading cause of death in the entire world. So it is critical that we take a very aggressive approach to blood pressure and see why this plays such an important role in our body's homeostasis. So with blood pressure, there's two major pressures we need to be aware of. We have the systolic pressure and we have the diastolic pressure. Remember, systole means contraction and diastole means relaxation. So our body's systolic blood pressure is the pressure inside of our blood vessels when the ventricles are squeezing and blood is flowing into the vessels. That's going to be the rebounding that you feel when assessing the pulse. Naturally, as the ventricles pump more blood into the blood vessel, that's going to increase the pressure inside of the vessels. Now conversely, we also have the diastolic pressure, which is the pressure inside of the vessels when the ventricles are relaxed and are filling up with blood. So naturally, the systolic pressure will be greater than the diastolic pressure. Normally, the systolic pressure is right around 120 millimeters of mercury. And the diastolic pressure is right around 80 millimeters of mercury. So the way that we would write our blood pressure, systolic over diastolic pressure, would be 120 over 80. That's a healthy blood pressure. Someone with high blood pressure may have a systolic pressure anywhere above 130 to around 160 and beyond. And when diastolic pressure is high, we'd consider that right around 90. So especially if you're a nursing student, you're going to need to know how to check blood pressure. You do this using a stethoscope and also a sphygmomanometer, which is definitely a mouthful to say. The colloquial term for a sphygmomanometer is the blood pressure cuff. So you'll use a stethoscope and a blood pressure cuff to check blood pressure. So the first thing that you're going to do is you're going to take the blood pressure cuff and put that around the upper brachial region of the upper portion of the arm. You're going to pump air into the blood pressure cuff to the point that the brachial artery is compressed because the pressure in the blood pressure cuff is higher than our body's systolic pressure. And that's when you're going to listen for the Karot cough sounds. Now the Karot cough sounds are not S1 and S2. They are not the lub-dub sounds, so don't get these sounds confused. The Karot cough sounds are going to indicate the systolic pressure and the diastolic pressure. So at the point that you'll hear the first Karot cough sound is when the blood in the brachial artery is beginning to flow again because the pressure in the blood pressure cuff has just dipped below the systolic pressure. Wherever the mark is on the gauge of your blood pressure cuff, that's going to be your systolic pressure. Now the diastolic pressure is the last sound that you're going to hear when assessing blood pressure. So you have to make sure that you are paying attention to this very, very carefully to make sure that you get an accurate reading. So you've got the blood pressure cuff wrapped around the upper portion of the arm. You have the stethoscope that's placed right in the antecubital region, listening to the brachial artery. The first Karot cough sound is the systolic pressure, and the last sound is the diastolic pressure. Now, you won't actually have to take someone's blood pressure for the exam, but you do have to know how we assess blood pressure and what tools are going to be relevant. So lastly here for blood pressure, we want to be able to calculate our body's mean arterial pressure, which is the average blood pressure that our vessels are undergoing throughout the course of the day. Blood pressure is always changing, and it's normal for blood pressure to change. When we go and exercise, that is one thing that's going to significantly increase blood pressure. Getting into a fight with a significant other, or perhaps almost getting in a car crash, are two other things that are also going to likely get your blood pressure up. So we have to have a way of assessing what the mean arterial pressure is. And we've got a couple formulas that I'm going to share with you to help us calculate this. So first and foremost, we need to determine what the pulse pressure is. The pulse pressure can be calculated by taking the systolic pressure and subtracting the diastolic pressure from it. This is describing the difference that the blood vessels are feeling from the stretch of the systolic pressure to the diastolic pressure. If a healthy blood pressure is 120 over 80, we would end up with a pulse pressure of about 40. So 40 is right around the baseline of what we want our pulse pressure to be. If we go any higher than this can potentially cause a lot of damage to the elastic tissue inside of our blood vessels. The greater those vessels are having to stretch to accommodate for that increased blood pressure, the more work those vessels are doing for keeping the blood contained. So that really stresses the elastic tissue in the vessels. So this can damage our blood vessels if the pulse pressure is too high. Now, atherosclerosis, which is the obstruction of vessels, is also going to increase the pulse pressure because there's less space in the vessels for the blood to pass through. So one place that we can actually see this is with a garden hose. If you were to put your thumb over the top of the garden hose, that's going to significantly increase the pressure and speed of the water flowing out of the hose. If you're anything like me, I used to use this trick to get back at my brothers when I was much younger. So that's actually quite an accurate example of what atherosclerosis is like. So you can see here we want to keep the pulse pressure under 60. Now once we've calculated the pulse pressure, we're going to divide it by 3, and then we're going to add that to whatever the diastolic pressure is, and that will give us our mean arterial pressure. So if we have a blood pressure that is 120 over 80, the pulse pressure is 40. Dividing 40 by 3 is roughly 13.3, and we take 13.3 and add that to the diastolic pressure, which is 80. So 80 plus 13.3 is 93.3, and that is right in the middle of our normal range for our mean arterial pressure. We, of course, don't want our mean arterial pressure to be too high because it can damage our blood vessels. But we also don't want our mean arterial pressure to go too low, otherwise we're not going to have enough blood pressure to get blood up to the brain, to get blood through the coronary arteries and perfuse the actual heart tissue, and also in the kidneys. Now let's consider an extreme example of high blood pressure. Let's consider an example of someone who has a blood pressure of 150 over 100. If our blood pressure is 150 over 100, in order to calculate the pulse pressure, we're going to subtract the systolic pressure from the diastolic pressure, and that's going to be 50. 50 divided by 3 is roughly 16, so we take 16 and add that to the diastolic pressure, which in this example was 100. So that is a mean arterial pressure of 116. So you can see how that number goes up, and that can cause a lot of damage to the blood vessels. So finally, I've taken this picture from your textbook to piece together the phases of the cardiac cycle with the volumes in the chambers, the heart sounds shown here, the EKG tracing, and the pressures that are changing throughout the heart throughout the course of the cardiac cycle. You can see atrial systole and ventricular systole shown up here as well. So I'm not going to go through this entire chart here. You guys can look at this as an aid to your studies. So that will conclude our presentation on cardiac function. If you have any questions about this material, as always, please feel free to reach out for assistance. I'll see you all in our next lab presentation where we're going to start discussing the blood vessels.